So tuberculosis, I think we have had a lot of interesting lectures since morning, and actually tuberculosis is defined as there is no disease which inflicts such deep wounds on mankind as this. So tuberculosis has been there for provenly, for about 9,000 years as isolated in a graveyard in Eastern Europe, but still it causes huge amount of suffering in various groups of people up to date, and it is estimated that about 10 million people get infected with tuberculosis, and about 1.5 million die, and unfortunately most of them are in the developing countries. So this is actually when Robert Koch visited in 1901 to the British Parliament on an invitation to discuss about tuberculosis and in the United Kingdom. So even though we think that tuberculosis has a bleak outcome, there are certain new developments which I'm planning to discuss with you today, which gives us a glimpse of hope in future regarding tuberculosis, which is the #1 dreaded disease, infectious disease in the world today. And COVID was able to surpass it for about 2 or 3 years, but still TB is a huge problem today. Robert Koch identified that AFB bacilli. We are thinking about the diagnosing of tuberculosis with his methods. After his sentinel presentation, we are using his methods up to this moment. Are there any new developments? Probably Dr. Mudita will go and discuss about some features. I really want to go into certain details about novel diagnostics, because we have a good scope of diagnosis. Another important armamentum in the diagnosis is the X-ray. This is actually Wilhelm Röntgen's wife's hand, the first radiograph ever taken, again about more than 100 years before. Still, we are relying on radiological diagnosis. Do we have any other methods of diagnosing, especially in the field of artificial intelligence? There are new scope in diagnosing tuberculosis. And vaccines is one of the most important aspects. We are still using a more than 100-year-old vaccine, which is not that effective in preventing tuberculosis in adults. But unfortunately, some of the vaccines are in the pipeline, fortunately, but still not come into the clinical practice. We will be discussing some aspects of these vaccines as well. So regarding treatment, that is the most important thing that I will start my presentation. So the first anti-tuberculosis drug was identified in 1943, developed by Schwartz, streptomycin. But as we already know, it soon developed resistance when it was used as a single drug. Then the multiple combinations of anti-TB drugs in the 1960s by Campbell were proven to be effective, and around 1990s we found rifampicin, 1980s, but since then there was a lack of new drugs and new regimes in tuberculosis treatment. And we use for the drug regime that we use now, we use 4 drugs, 2 drugs in the intensive phase and the 4 drugs in the continuation phase for drug sensitive tuberculosis, and the treatment for multi-drug resistant tuberculosis was much cumbersome. There's a huge amount of pill loads. The patient has to take a lot of pills for a long time. And I would, I would ask you doctors, if you are prescribed for example, coamoxiclav 8-lavity for 5 days, how many of you will be taking for 4 to 5 days, right? So remember, we are dealing with patients who are taking drugs for 6 months, sometimes even 18 months, and sometimes we have to use injectables as well. But fortunately, during the last 3 or 4 years, there are developments where we are able to reduce the duration of anti-TB treatment into certain extents. One aspect, mainly the drug-sensitive tuberculosis. There are 2 studies actually done, which has compared rifampicin, isoniazid, pyrazinamide, and moxifloxacin given for 4 months, compared with the normal regime that we are using. And there was another arm in that study which was combining rifampicin, isoniazid, ethambutol, as well as pyrazinamide for 4 months, all 4 drugs given for 4 months. And the rifampicin, isoniazid, moxifloxacin, and the pyrazinamide combination has proven to be non-inferior than the 6 months treatment that we are currently giving it. And the recommendation has now come into the WHO recommendations, and at the same time CDC is also recommending us sometimes in the first line of treatment for drug-sensitive tuberculosis. So we have a new drug regime with 4 drugs. Can we use it in Sri Lanka? We know that rifampicin and moxifloxacin is expensive, and sometimes we might be hindered by the use of these drugs in the future. So probably at the moment for Sri Lankans, we might be able to go for the 6-month regime until further developments come. So about the drug-resistant tuberculosis, I think we have a huge problem with treating drug-resistant tuberculosis. The duration was sometimes about 18 months to 2 years of duration, and they had toxic injectables which we had to keep the patient in, or the patient had to come and take the drugs in the regular dose. But during the last 4 years, I think that's a huge development in, and even though we give the treatment, the success rate was about 50%, sometimes 65% in drug-resistant tuberculosis. But during the last 4 years, during various studies like the NICS and the practical study, we are now able to have around 6-month treatment regimes for most of the drug-resistant tuberculosis. So we have basically 2 regimes at the moment to give drug-resistant tuberculosis. If there is no fluoroquinolone resistance, we call the BPALM regime, that is bedaquiline, linezolid, moxifloxacin, and protamidine for 6 months duration. And if the patient is having fluoroquinolone resistance, then we go for the BPAL regime, that is bedaquiline, linezolid, and moxifloxacin for 6 months. So these drug regimes, compared to the 60% success rate, has about 89 to 92% success rate with minimum side effects, and it is now almost always the standard of treatment in drug-resistant tuberculosis, except from exclusion patients in the who are there. And there are some pipelines drugs that are being developed in the world. Hopefully within the next 1 or 2 years, we'll have a better outcome of drugs where we will be able to give shorter regimes, which is less toxic to the patient, and hopefully it doesn't have any injectables, and we might be able to have a very high success rate in multi-drug resistant TB as well as drug resistant tuberculosis. So things are looking brighter in the treatment aspect. So I just wanted to highlight about the diagnostic. So this is, I think you have heard about Frederick Chopin. Chopin is one of the most important composers in Europe that we had. So he said that regarding a diagnosis, I mean, he went to a doctor, but they have done one sniffed at what I spat out, the second tapped where I spit it from, the third poked about and listened to how I spat it. One said I was going to die, the second said that I was dying, and the third that I was dead. I can scarcely keep them from bleeding me. So there's one treatment that they have done was usually they use a lot of bloodletting in the European treatment regimes. But this says the diagnostic problems that we face when we have in tuberculosis. Sometimes the management problems has the prognostic problems as well. So this actually lady presented the similar way to me. A 60-year-old lady has 3 episodes of tuberculosis, not 1, 3 episodes of tuberculosis, 2019, 22, and was started as anti-TB treatment, but still, plus after the second episode also, this patient came with loss of appetite, loss of weight, and mild worsening of cough. And we can see this fibrocavitatory lung in this patient, and in the left side also it is completely involved. The patient was cachectic, patient was having hemoptysis as well. And when you look at the summary, we can see that the patient has been twice proven bacteriological tuberculosis, given treatment, and the third episode, this patient has come AFB positive, but the gene expert is negative, and treated with azithromycin. And then we found that in the culture, the patient was having mycobacterium tuberculosis other than tuberculosis. So just to say that sometimes tuberculosis causes diagnostic dilemmas. Even though now we have a much diagnosis in this patient, probably the patient would have been treated as tuberculosis again in this patient, but fortunately we had the diagnostics, but still it is not enough because we want to go for diagnostics, and this is what we were able to send this sample to India for the whole genome sequencing. Just wanted to highlight this case that we have, and it is available, and it's about 49,000 to 50,000 rupees. So whole genome sequencing is what what we do is we grow the tuberculous bacteria, and then we isolate the DNA, and we compare with the library of genes that is there in the internet and in certain platforms, and then we can come into conclusions. We can identify the species of tuberculosis. Now, in this patient, it was identified as a MOT, non-nectar tuberculous mycobacteria, and it is Mycobacterium intercellular subspecies. And at the same time, you can identify the resistant patterns of bacteria as well. So whole genome sequencing can be the future of diagnostic tuberculosis, especially in patients who are not responding to treatment, patients who are having diagnostic dilemma in the future. So this is available to us, and we can use it in a nice way to help us in the diagnosing and management of our patient, because it will help us to diagnose tuberculosis, to identify whether there is drug-resistant tuberculosis, and at the same time, we might be able to trace people where this patient got the tuberculosis as well. So it has public health implications as well, right? And the second one, I think, sir, discuss about the immunosuppressed patients. It's very difficult for them to be diagnosed. And one of these investigations, I think Budita certainly would have discussed about lipoarabinine MANE in patient, especially in patients with HIV, where there's a low CD4 count. What happens is, in the Mycobacterium tuberculosis bacteria, there's a lot of lipoarabinine around the bacterial cell wall, and this is actually secreted to the urine, and it is usually captured by our immune cells, the immunoglobulins, and usually the free lipoarabinine is very, very low in a normal person who is having an immunocompetent state. But when you have an immunocompromised state, this urine contains a lot of lipoarabinine, which is sensitive and specific for diagnosis of tuberculosis, especially in patients with HIV who have immunocompromisation, and certain patients who are immunocompromised due to other reasons. Urine lipoarabinine, which is a non-invasive investigation, and it doesn't need invasive sampling as well. And even if these extrapulmonary tuberculosis, this is a very good method of diagnosing tuberculosis, and we are trying hard, and so and I was actually discussing in the technical group as well, to bring this lipoarabinine as early as possible to the Sri Lankan context. It's like a simple pregnancy test. Takes about 30 minutes to give the diagnosis. Even if we have a 50% sensitivity, that will be more than enough. But immunocompromised people has a 70% sensitivity, and there are now new developments of lipoarabinine assays in the world, where there are companies developing, and in this group of people, in this method, even in immunocompetent people, and especially in children, where we have difficulty in taking samples. We know how difficult to take samples from the children. We could NG tubes, we could get gastric lavages. So and in children, the extrapulmonary tuberculosis burden is higher than pulmonary tuberculosis. Obtaining sample is very, very difficult, especially in children. Lipoarabinine, even if the sensitivity is 50, that is acceptable. So hopefully this will be available in future in Sri Lanka as early as possible. And it has been proven, and especially in a non-HIV people, also lipoarabinine, urine lipoarabinine has been proven to be of benefit. Especially the newer platforms are giving a very good sensitivity in diagnostic yield, right? So this is actually to highlight some people might have only lipoarabinine possibility. This is culture smear RNA studies, which is the proteomics that we do, and the gene expert, and you can see that even some people, all the people will miss, all the investigations will be, but there is some that will be lipoarabinine might be positive in certain groups of people. So it has a good sensitivity. So even though we have Gene Expert, we have Gene Expert Ultra, so sometimes sampling is very difficult, and we might have to think about novel sampling methods. One such sampling method is doing a mask. The patient was actually asked to wear a mask only about 30 minutes, and unfortunately in this study, the mask yielded a poor outcome for these patients, especially in children who doesn't cough. So simple breathing we might be able to catch the diagnosis as well. But they have, especially this in India. In India, they have improved this method, and they have included gel pad in the mask. And the patient has been asked to wear this mask for probably about 24 hours. And then when they analyze this sample, they have high yield of diagnostic. So this is a non-invasive method that has been used. So current methods can be used combining with novel think processes in diagnosing tuberculosis, especially when the samples are difficult to take. And this is again oral swabs in patients, especially adults and children. When they take oral swabs for diagnostic, gene expert and culture, there have been positive yields in certain groups of people. And when combined with various methods like boiling the sample, swab, and increasing the sensitivity, they were able to increase the sensitivity to about 77%. So these are very simple methods. Tongue swabs taking for culture, for gene expert and gene expert ultra, where you can increase the yield. You can take multiple samples. So we know that sometimes it's very, very difficult to take samples from people. And if we can do this, there will be increasing yield of diagnostics as well. And another important thing is the centrifugation of samples. When we take, it will increase the yield as well. We did a recent study together with the Colombo University where we are able to centrifuge the bronchoalveolar lavage sample, and the centrifuging was shown to be able to increase the yield of even gene expert positivity in patients with tuberculosis. And we presented it in Respire 2025. So there are other methods of diagnosing patients, especially in children. Stool TB PCR is one of the important things. Again, children, you can't actually have invasive methods. So stool PCR is another important method that is going in, and there are other biomarkers that are on the development pipeline. So future is not that bleak when we think about diagnostics. The important thing is we should know about these diagnostics and try to implement it in our Sri Lankan context to improve the diagnosis of these patients. So we heard about latent tuberculosis, we heard about active tuberculosis. Tuberculosis is not a very simple disease, as we all know. Even though we have divided into active and latent, sometimes there are many, many ways that tuberculosis can present, right? So what we know is that there is latent tuberculosis, active tuberculosis. You get treated or you die. But tuberculosis is not simple. There is what we call the latent tuberculosis, and we have what we call the subclinical tuberculosis, where there are radiological abnormalities, and sometimes you might be able to culture these patients' sputum and other organisms from the viable bacteria from the lung, right? This is the subclinical, but they will not have any symptoms. So there are a group of people with tuberculosis who will not have symptoms but will have active tuberculosis in their body, and this is the group that we call subclinical tuberculosis, and they have the possibility of spreading the disease to another person, and at the same time they have a possibility of progressing into active tuberculosis as well. So this paradigm, this important group of people is very important when we are thinking about the epidemiology as well as the tuberculosis scenario in the world, because we know that in Sri Lanka we are trying to find this 4,000 as much as possible. We have a gap, diagnostic and the treatment gap of about, diagnosing and the estimate gap of about 4,000 people. And when you look at these 4,000 people, many of them, especially the close contacts of tuberculosis, probably would have had subclinical tuberculosis. So what is the clinical relevance? Can we diagnose these patients? So this is in Mozambique. They have a prevalence of tuberculosis about 840 to 100,000. So this group is the abnormal X-ray and noticeable symptoms 290, and we have noticeable symptoms only in about 30, abnormal X-ray only about 597. But there will be a group with a normal X-ray and no symptoms, and we really don't know what the burden is. And these people will progress into tuberculosis. So do we have methods of identifying this group? Fortunately, yes, right? This is the graph that shows basically that these people who are having subclinical tuberculosis can give the disease to another person, right? And hence, what we need is actually in diagnostics in tuberculosis is that we need a new paradigm of diagnostic methods where we can identify patients who are having MTB infections, maybe the latent tuberculosis patients, and then there will be active replication of tuberculosis. We call the incipient tuberculosis. Then they will have the subclinical tuberculosis, and then the active tuberculosis. So if we can actually identify patients at the subclinical level and the incipient level, we might be able to give probably shorter regimes and prevent the patient from sending the disease to another person as well. So that is basically the future of tuberculosis in treatment. Rather than when the patient is having a 3+ AFB coming to you, probably giving the disease to at least about 20 people per year, estimated. If we can catch these patients at this stage, especially the close contacts, there will be the future of tuberculosis in future. So do we have methods of diagnosing? We know that TST and IGRA are not very efficient in diagnosing the latent tuberculosis as well as subclinical tuberculosis groups. Right? And there are methods now currently developed, simple methods that are there in diagnosing these patients. So we have this patient who is having mycobacterium tuberculosis infection, and they don't have the disease at the moment. And then what happens is this patient will then go into this level where there will be secondary tuberculosis infection, and still most of these patients will have what we call the transcriptome. Transcriptome is the what we call the transcription of mRNA. So when a patient gets infected with bacteria, we know that certain silent genes that are there in our body get activated, and they can actually produce mRNAs that we are calling non-coding mRNAs. They don't produce proteins, but they are very important in activating genes. So there are certain transcriptomes or certain mRNAs or micro-mRNAs that we can identify, especially in patients who are infected with tuberculosis. And the second group is the T-cell activation. So especially the CD8 cell activation can give us a clue about tuberculosis activation. And the third important thing is the monocyte to lymphocyte ratio. In tuberculosis, the monocytes will be high, the lymphocytes will be low. So there are various markers that are currently going through various studies in identifying patients with tuberculosis. And this is basically a summary. So in TST, IGRA will be positive in active and subclinical disease to a certain extent, but the patients will not be positive in other infective groups. So this graph is a very important graph that I would like to share with you. Now, latent tuberculosis, the most important thing is now we have also started treating latent tuberculosis. So look at this number needed to treat latent tuberculosis. If we go for positive IGRA and positive TST, the number needed to treat to prevent one tuberculosis patient from happening is about 85 for IGRA and 250 for TST. So every MAN2 positive patient, we had to treat about 250 patients to prevent one active tuberculosis patient. So this is a very low, very high number needed to treat. The idea would be about 10, and we have not yet reached it, except for this correlation of risk, where we can go for the 16 gene transcriptomes, where it has shown in studies the number needed to treat is 37. This is where patients' blood will be analyzed, and we will be seeing certain RNA molecules in these patients, and from that molecules we can identify whether this patient is infected with tuberculosis or not. And that method has proven to be having an NNT of 37, but still these are at the study levels. Hopefully within the next few years it will be developing into active reality, so that we will not have to treat thousands of patients with INAH with very severe side effects, 6 months treatment unnecessarily, and we can actually get the patients who are having incipient or subclinical tuberculosis and treat them appropriately, rather than treating the whole population, which has a risk of giving INH monoresistance as well. So there are new pipelines, and I would like to highlight this CRISPR. CRISPR is a very interesting method, and this lady, two ladies who developed CRISPR got the Nobel Prize for I think it's biochemistry or medicine. So in that, what they identify, we think that bacteria don't have an innate acquired immune system. Actually, when the bacteria is infected by a virus, this bacteria can keep that viral genome in its genome, and then whenever the bacteria is attacked by the same virus again, they can actually reactivate it. And that is what we call the CRISPR method, CRISPR-Cas method. And that CRISPR-Cas method, the important thing is it is so specific, and it can closely bind and actually bind to a direct gene or direct DNA sequence called PAMS, and that is helpful in diagnosing tuberculosis. So especially CRISPR-Cas12 system has now shown to be beneficial in diagnosing tuberculosis, because they attach a fluorescence mechanism to this one. So it's really exciting. I know that sometimes it's really difficult to understand, but just to give you we are doing, in the tuberculosis field, there are a lot of things that are happening in the field. So the tuberculosis that we thought that we knew is completely different from the actual tuberculosis. So there are newer methods that are coming in these patients. Right. So during the last 2 or 3 minutes, I would like to go into vaccines. So there are various types of vaccines in development. Some are live attenuated in green. Some are actually whole cell vaccines. Some are vector-borne. Some are subunit, and some are boosted by various augmenting factors like adjuvants. So there are three important vaccines: MTB-VAC, WPM 1002, are there, and it can be given to neonates, it can be given to adults, and it can be given as a therapeutic action as well. So sometimes these vaccines, we need one thing to prevent active tuberculosis. The second important thing, prevent probable latent tuberculosis develop into active tuberculosis. And sometimes we might need vaccines to boost the immunity in patients who are having active tuberculosis to prevent severe disease. So this NTB-VAC as well as VPM 1002, which one is actually developed in India, are two promising agents. So this is actually the important vaccine that we call. Now here, what we have done is the BCG vaccine that we have, we know it is a Mycobacterium bovis vaccine, and it is attenuated. The region of differentiation that is producing ESAT6 and CPD10 is attenuated. The virulence is reduced, and this vaccine is actually developed by doing that. And there is this vaccine again. What we have done is basically we have deleted two genes in this genome, and then the patients are given this vaccine. Actually, these are vaccines that have made less virulent, the same vaccine which have been made less virulent. So it's in the pipeline. Why are we worried about vaccines? Why do we need vaccines? So this is the projection of tuberculosis in the next few years. So we are, within our lifetime, whether we will be able to eradicate tuberculosis in the world, probably not. Whether we will be able to eradicate tuberculosis from Sri Lanka, we are planning high hopes of 2030 and probably 2035. We will hope for the best and stay. But unless we develop a vaccine for tuberculosis, we might not be able to eradicate tuberculosis from the world by 2035. So this is the projection, that we should be developing a vaccine in 2025, efficacious vaccine in 2025. But still, up to date, we still don't have vaccines that have come into the clinical practice. Most of them are stage 3, and unfortunately, we don't have a current vaccine. So unless and until we develop a vaccine for tuberculosis, we might not be able to eradicate tuberculosis, and the thousands of people will be dying. So we might have to, in a daily basis, fight with tuberculosis. Hence, the most important thing is to have improved diagnostics, to identify patients at the earliest level, probably incipient level or subclinical level, before they start spreading the disease to another person, and identify them and probably treat them with short regimes of treatment which might be effective. The second thing is, when we have what we call active tuberculosis, treat them with short regimes which are effective. So we have short regimes at the moment that are approved by the CDC and the WHO, 4-month regimes. Probably we can bring them further down, which are affordable to the country. And the third thing is, we have to have increased diagnostics to identify these patients. And then hopefully we will be able to manage tuberculosis. And I think hopefully we, as a human race, we should pray that we will be developing a tuberculosis vaccine within the next 5 years. So before we die, we might be able to see tuberculosis eradicated. Thank you very much.